welcome to this week's weekly Monday deep dive. It is really, really great to be here. I see you getting a side view of me. I'll turn slightly towards the camera. We've got a very, very exciting and important session ahead of us, about which I'll tell you in a moment. But as you can see, we're talking about antiphospholipid syndrome and specifically the laboratory testing elements, as well as the latest updates from ACR and EULAR on how to classify this condition. Now, for those of you who don't know and who are new perhaps to today's to the deep dive, this is a weekly meeting that is jointly run between all the divisions, departments of hematology in the country, both hematopathology and clinical hematology. And every Monday afternoon, we have an hour and a half of academics and teaching and sharing experiences. And we really welcome all of you who are perhaps not yet on our mailing list to contact us. Also note that the recordings of previous sessions, if you've missed them, are on the Blood SA website. As you can see on this slide, bloodsa.org.za. And you can go back and review, especially those preparing for exams, because as a reminder, the deep dive was really started with the aim of helping registrars and fellows training in hematopathology and clinical hematology to prepare for exams. But in the meantime, it has expanded far beyond that, excitingly so. Any questions or discussion, please use the chat box. You can also speak up when the time comes. You're very welcome. And you can see there Melanie Davids, our secretary's email. If you want to be added to the mailing list, please make a note of that email address and send her an email. If you're from South Africa, CPD points can be automatically submitted to the HPCSA if you have registered with your MP number. But please note that you will have to attend a full hour to qualify for that. Otherwise, the system automatically throws you out. Not to be bad, but, you know. So, also at the end, there's going to be an anonymous feedback survey. We really appreciate your input. We want to make this better and better. So whatever we can only do that with your help. So thank you in advance for doing so. We always remind ourselves and each other of the upcoming conferences related to hematology. And we've got the International Donor Registry Conference and WMDA meeting in June in Cape Town. So please note also that there are discounted rates for members of any of the societies that you can see on the screen. The Hem-Onc, of course, it's going to happen in September. The program is really shaping up and looking great. Please block your diaries for the 13th to the 15th of September. We want to see all of you there. Then, and I'm so happy to see that we've got Bridget McMillan's face on the screen now that I've always wanted there, together with Melanie, Gerdien, and Prof. Stelverberg, who organizes and manages the deep dive sessions. So we say big thank you. Bridget is sitting here across from me. Thank you to all of you for the great, great work you are doing. We really appreciate it. And before we get to today's topic, I just want to give you a heads up that next week we will have a session on hemophilia A, joint health in hemophilia A in an evolving treatment landscape. Very important topic for clinical practice and for exams. So look forward to seeing all of you. Now, with that, it is really my great pleasure to introduce Professor Jessie Chow, who I was so fortunate to meet last year in Nashville when I visited the SABM conference. And I met him and his wife, who is from South Africa, by the way. And we just really hit it off. And we started speaking about the possibility of visiting South Africa and coming to also give talks here. And all of this has now come to fruition. And here we are. So Prof. Chow is a clinical associate professor in the Department of Pathology and Laboratory Medicine at the University of California, Irvine, which is a very well-known place, and is board specialized in blood banking and transfusion medicine, as well as anatomical and clinical pathology. and he completed his medical degree at the University of Texas Health Sciences Center in San Antonio. So he speaks on many things. His interests are quite wide, amongst others, viscoelastic testing for patient blood management, iron deficiency. We're fortunate to have him here tomorrow for a journal club on that. And more specifically, an area of interest to him is anticoagulation and lupus anticoagulant testing strategies. So with that, Jesse, it's my great pleasure to welcome you here today, and we look forward to learning a lot about this topic that can sometimes be really challenging, especially if you've got these odd single positive antiphospholipid antibodies that stresses the patients out so much.
Yeah, I know.
I actually just had a patient like that last week. So I really look forward to learning from you today. And I'm going to hand over the screen to you. Thanks so much.
Awesome. Thank you for the introduction. Okay. Well, thank you everybody for being here this actually in America currently at 7 o'clock in the morning. But thank you for everybody coming this afternoon. I'm Jesse Chow, and I recently joined UCI in the past. It's been just a year now that I joined UCI as a faculty there. So I'm actually over the I'm actually the head of the laboratory in the coagulation, and also the associate director for blood bank transfusion medicine as well. Okay, so let's go into the learning, right? Learning objectives. So we're going to first be talking about the pathophysiology of APS and the classification criteria. Then we're going to talk about this testing for serology and how it applies to the latest guidelines. And then we'll talk about the lupus anticoagulant testing methodology for APS. And lastly, we discuss some challenges, right, for the testing, particularly with anticoagulation interference. So before I begin, I'd like to use a slide. This is a very simple way to explain complex things. Balance is a key to life. Okay, because coagulation, right, it's not just some diagram that you draw on the paper, but it's active, right? When you have balance, right, in your procoagulant and anticoagulant factors, you have balanced hemostasis when appropriate. Now, hemostasis is physiological. Thrombosis is pathological when you have too much favor procoagulant activity and less anti-activity, and likewise, when you have imbalance the other way, it's called bleeding, which bleeding. So, anyways, so APS. So APS. So I'm going to use APS, right? Because I don't want to pronounce antiphospholipid syndrome. APS is an autoimmune disorder with the symptoms that are attributed to a pathogenic antiphospholipid antibodies. So this creates a pro-thrombotic states. Okay, that now, so this may be associated with lupus or SLE, but not always. Female prevalence is more greater than males. Now, because of the presentation, right, that's very heterogeneous, contributing factors and pathology, the actual incidence is not clearly established. Okay, so features of APS. So APS is most classified by arterial, venous, or small vessel thrombosis, or you may have pregnancy morbidity, immortality, fetal mortality, fetal loss, right? You may have premature preeclampsia, associated with preeclampsia, and spontaneous abortion, consecutive. Okay. Now, there's other features of APS. You may have what's called livedo reticularis, which is basically skin lacing the skin, right? Let's see on the right here, lacing the skin. You may have ulcerations, you may have low platelets and hemolytic anemia, valvular heart disease, and kidney issues, and most notably thrombotic nephropathy. Catastrophic APS is when you have more than 3 organs affected, and you have a rapid onset of action, okay, demonstration of the antibodies. You have loss of life and limb, okay. Now, this is APS it does require lifelong anticoagulation. So unfortunately, these patients have a bad quality of life. Okay, worse quality. I should say worse quality of life compared to right the patients who are healthy. Not to speak of anticoagulation also adds additional risks of bleeding and recurrent thrombosis. Okay, so how is APS, right? So how's APS manifest itself? Well, there's what's called a two-hit hypothesis, right? First of all, you must have antiphospholipid antibodies must be present. Okay, you must have something to demonstrate to be able to mount an attack. But second of all, um, um, these antibodies, right, when they're in, I guess you can say, right, wrong place, wrong time, right? When they trigger complement activation and trigger activation of coagulation, under normal circumstances, you would not have activation of this, but because you have antibodies that interfere with the normal physiologic processes, it essentially creates different parts of the activates different part of the pathway. Okay, so here the bond, right? Here's an example of a antiphospholipid antibody binding to this important protein, which we talk later about the beta-2 glycoprotein I, a important regulator of coagulation. Okay, so these antibodies are heterogeneous, which means nothing is exactly alike. That's why the pathology, right, and across different people is varied. So they target either phospholipids directly, or they may target targeting phospholipid binding proteins. They can affect monocytes, causing activation and increases expression of tissue factor, which we know can activate the extrinsic pathway. In endothelial cells, they can cause dysfunction, impair fibrinolysis. You can activate the coagulation cascade, mainly by interfering with beta-2 glycoprotein, but also protein C, AT3 inhibition. They can also activate platelets via the beta-2 glycoprotein I binding and cause aggregation. And lastly, they could mess with complement, via the annexin A5 and the C3 pathways. Okay, so the evolution of the diagnostic criteria. APS has been described for decades, right? Which I'll talk about later. But the first formal criteria was classified in 1999. That was the Sapporo criteria. Then we have in 06, Sam Yerksendat, who was a revision to the criteria. And between 06 and in fact, the end of last year in August, been a 17-year gap, they have updated they had a major revamp called the 2023 ACR, American College of Rheumatology, and European Latin Society for Rheumatology classification criteria. So just to show you the timeline things. So let's go over first the criteria back in 1999. So number one, this criteria was preliminary, which means it was meant to define the essential features of APS, mainly to help patients, to classify patients and to treat, and to see if there's any cause and effect, right? Now, you want to have at least one clinical criteria by this definition, which included one, vascular thrombosis, either arterial, venous, or a microvasculature in any organ, in any tissue, okay? And if it's biopsy, then it should not be right due to inflammation, vasculitis. Or you may have pregnancy morbidity, and which is more than one unexplained fetal death over 10 weeks, more than one premature birth, less than 34 weeks due to preeclampsia, or you may have 3 consecutive miscarriages, less than 10 weeks. It can exclude by normal karyotype. Laboratory side, you must have demonstration of at least one of the following. It could be a lupus anticoagulant, demonstration of that tests positive twice, at least 6 weeks apart. Now, the interesting thing is that this criteria, they actually spelled out the ISTH guidelines. First, they must have PDT, right? Then they must have mixed studies. Then they must have lupus, and so forth. It was essentially copied from ISTH guidelines. Demonstration of this, or you may have the demonstration of the anti-cardiolipin antibodies, IgG or IgM. Again, medium high titer, 2+ occasions, at least 6 weeks apart, using ELISA. Now, if we look at the 06 revision, right? This is fast forward 7 years. If you notice that in the 06 version, and by the way, if you feel free to to look yourself at the actual criteria. So I just kind of made like a summary version of it, right? But the 06 criteria included beta-2 glycoprotein I, anti-beta-2 GPI antibodies, in addition to the chirolectin antibodies. There's not much change. There might be some minor changes in definitions of what constitutes as pregnancy morbidity, but essentially this is the same, but the laboratory side has been updated. The most important thing is that demonstration of 12 weeks instead of 6 weeks. So you want the time interval to go 12 weeks apart. Okay. So but then in 06, the challenging part is that there are some in the 06 criteria, they recognize some of the clinical features and lab features that were mentioned, but they're not unable to fully or formally classify. This is termed probable APS. So your clinical features included patients with heart valve disease, patients with libido reticularis, which is a lace-like skin, thrombocytopenia, nephropathy, and neurological manifestations too. Laboratory side, so what do we do about the IgA antibodies, right? We don't know. How about the other antibodies, anti-phosphatidylserine antibodies, and anti-phosphatidylethanol, whoever, this is like very long. Anyways, these antibodies, right? And you may have antibodies to the prothrombin complex. Okay. So, which is the reason why we have the latest 2023 update. So this is actually made by an international consensus by the American and European Latin American societies. Basically, they validated criteria by 4 phases. By 1, generation surveys, going back to the literature, and they also helped formulate the different groups that you may categorize in, to use of consensus-based definitions using weighted criteria. So it's no longer 1-on-1. Okay, so you have weighted points that are defined by each, depending on what you're dealing with, your scientific points for every symptom, right? And then followed lastly by validation from independent sources and consensus as a gold standard. So essentially, instead of okay, I need 1, right? I need 1 to diagnose. I need 1-on-1. Now all you gotta do is all I need is one clinical symptom. You don't have to be APS, right? It could be any clinical symptoms on the table. You need 1 of those and 1 instance of positive lab testing to serve as the entry criteria. And this is so to further assess the possibility of APS. So the way I see it is that this gives clinicians, right, a chance to evaluate further and to keep it on the back of the differential instead of like, oh, it cannot be this, right? And also, instead of a 1-on-1 system, they use the domains. Clinical domains being 1 and 6, lab domains being 7 and 8. And if you notice that some of the prior associated symptoms of APS or the probable APS, but don't fit the example criteria, guess what? Now they're included in the criteria. Okay, they're included in the domains. One big one is, for example, nephropathy due to microthrombi. Okay, so classification of APS is based on weighted points system. You require at least 3 points in each of the lab domains. So, I'm sorry, you require 3 points in clinical domains 1 to 6, and 3 points in the lab domains 7 and 8. So the good thing is that if you compare this to the old criteria, specificity is much higher. Sensitivity it went down a little bit, but we'll talk about that. So this is example. This is the evaluation by the guidelines. I can explain a little bit of how this works, right? So, but essentially, let's look at the entry criteria, right? Does the patient have at least 1 clinical symptom and lab criteria from the table below? So, and if the answer, it doesn't matter right now, right? You're not looking at APS, right? You're just looking at, do I have that to start the process? So any patients, right, with any of these, yes, the answer is yes. Do I have at least 1 laboratory criterion, 1 laboratory test So for example, we had a patient at UCI where patient had one DRVUT that was tested 2 years ago. Well, that counts. So it doesn't have, and so basically you're looking for ways, right, to include first. But then the next thing is, let's look at the patient now. Well, the patient clinical criteria, are they most explainable by APS, right? I mean, think about it, right? I mean, this is hematology. Which patient in hematology do not have, right, low platelets, right? Everybody, right, has low, well, not everybody. Everybody, well, almost everybody has low platelets. But are the low platelets most attributable to APS and nothing else, right? So, and if they're equally likely, then you cannot use those points. So, so if you have established causes of APS, I'm sorry, for example, established causes of cardiac valve thickening vegetation by imaging, and there's no other clinical explanation for it. Like, for example, it's not rheumatoid arthritis, or it's not like other type of heart disease, then you may use it. So at the end of the day, you want to add up how many points you have here, and if they're over 3, okay, great. And they move on. Laboratory side, do we have enough points? Do we have enough points to make a score of 3 or total on the lab only? And if you have at least 3, or at least 3, then you may classify as APS. And I'll kind of explain this. If you notice that the lupus anticoagulant one-time positive is only 1 point, and also the IgM, which I'll talk about in a little bit, moderate high titer is also just 1 point. Everything else, though, everything else can get you score you positive on the laboratory side. Okay. So the strength of the 2020 criteria, right? It's because I think this version is very much comprehensive and is organ based, right? It allows for you to think about the patient organ by organ and to see are there any thrombotic, right, manifestations that may arise. And so basically, if your evaluation here is negative, right, essentially patients who are negative are going to have are going to be evaluated negative. So hence specificity has been increased to 90%. Okay. Now the challenges, right, the criteria. So there are updates on how do you triage catastrophic APS, which can be life-threatening. Okay. When you treat specificity, go up. I also got sensitivity can go down. So if you use this criteria incorrectly, you may lead to overdiagnosis. So again, use your clinical points only when they're better explained by APS and not by a different entity. Okay. So the next part we're talking about testing. So okay. So what are diagnoses should you be considering, right? APS. Well, you got HELP syndrome, you got your thrombotic TMAs, TTP, HUS, and AHUS, right? Lupus nephritis, that can happen with the SLE itself. You can have hypertension, that's malignant hypertension, and vasculitis. That's why oftentimes, if you have any renal involvement, getting a biopsy might be helpful. And also other causes of thrombophilia for unprovoked thrombosis. So let's look at the antibodies, right? So let's look at testing for the antiphospholipid antibodies. First section, we're going to talk about the testing of the actual antibodies by ELISA. And then second of all, we're talking about the clot-based assays, known as the lupus antibody. Excuse me. So let's first talk about the immunoassays, which is serology. This falls under domain 8 in the 2023 criteria. So, so first, right, it's going to be, first thing we'll talk about is called the anti-cardiolipin antibodies. And what does that mean by cardiolipin? Heart lipid, that's what it means. Now, I'm not speaking with cardiology because I'm going to get in trouble for putting a piece of butter next to your heart. But I'm glad this is hematology, but Anyway, so carrolapin, all it means is hard lipid. So hard lipids, so this is actually found in the inner layer of the mitochondrial, right? In the mitochondria, it is a negatively charged dimer using phosphatidyl glycerol, and this is involved in cellular metabolism and apoptosis. Now, now you may wonder, how did the antibodies form? How do you have antibodies that that form against those antibodies, right? Against the carrolipin. Well, that's because even though carrolipin is exclusively mitochondrial, the antibodies may cross-react. They cross-react, and including a whole range of phospholipids, including carrolipin antibodies, plastic proteins, and phospholipid and protein combinations. So ACO, so it's one of the most commonly encountered antibodies in APS. So ACL, so the ACL has been described since the 1980s. It was first described in a patient that has thrombosis with systemic lupus erythematosus. And ACL is detected by a solid phase immunoassay, or the ELISA, and currently still used today. So see, this article is from the 80s that first described the strong correlation between raised anti-carrolipin levels and lupus anticoagulin, which has also been known for decades, and venous and arterial thrombosis, thrombocytopenia, but no correlation with, again, so I believe anti-DNA antibody levels are associated with lupus itself, okay? So this is when it was first described as an entity. Then in the late 80s to early 90s, they discovered this cofactor, right? This cofactor for carrolipin. And later on, the cofactor was described to be the beta-2 glycoprotein I. Now, this is not a surprise finding because we know that people have studied beta-2 glycoprotein I before. And we know that beta-2 can regulate coagulation cascade in platelets. So this finding was actually very interesting, how they associated these same antibodies that can affect this protein that affects coagulation. Okay, it's a separate binding site. So, and ever since then, right, there's been more discoveries on the, talk about the discovery of they called it at the time carrolipin independent antibody binding, and she changes the conformation for the beta-2 protein, their association with the identification of lupus anticoagulins, and how these antibodies are just heterogeneous, right? Again, no two patients are alike, right? These antibodies can manifest in different ways. Okay, so beta-2 glycoprotein. So this is a protein that has 5 domains. Single chain protein with end-link glycosylation sites up here. It's produced in the liver and placenta, hence, right? You can imagine pregnancy complications, right? It circulates in plasma in both free and lipid-bound forms. Now, domain 5 is where the action is at because you have residues of lysine bind to the negative phospholipids on the platelets and endothelial cells. Domain 1 is oftentimes the target for the antibodies, but they essentially affect downstream the action of the domain number 5. Beta-2 glycoprotein I is an important regulator and mostly an inhibitor of normally activated coagulation. So here's a diagram of here's beta-2, right? So beta-2 so it has inhibition against ADP platelet aggregation. It also inhibits factor 11 activation by thrombin. It decreases the rate of formation of thrombin by inhibiting factor 5 and factor 10 activated, right? It enhances the activated protein C pathway, slows the phospholipid dependent processes, but also it can also inhibit to a moderate degree of fibrolysis. Okay. So when you have antibodies, right, that's bad. Okay. So unfortunately, the antibodies, when they're there, they can bind with, they can interfere with its effect on protein C, interfere with factor 5 and factor 8, leading to a persistence of generation of thrombin. It can also affect the complement, right, by annexing A2 pathway, and it can also decreases the plasminogen activity, decrease clot lysis, and trigger an inflammatory response, okay, which further makes things worse, okay. So now, what about the antibody isotype, right? We know that the antibodies, right, can come in a variety of forms: IgM, IgG, IgA, IgD, and IgE, right? So the technical message is that only the IgG, moderate to high titers, will score you enough points alone to classify as APS. Again, only IgG, moderate to high titers, will score enough points to classify as APS. IgM, in the past used to be a testing that you can classify, but you can see on the criteria that the IgM points has gone down. So IgM, and this is because lupus anticoagulants, right? Sometimes they can come and go, because you can see lupus anticoagulants with infections. But the ones that we're trying to catch here are the ones that are persistent. So you know that if you wait 12 weeks, at least we know that the immune response, right? IgG tells you that IgM is already formed. IgG, right? You have persistence. So that's why IgG is much more important than IgM. Now, if you have IgM with IgG, great. But you need to have IgG, moderate to high titer, and persistence is currently still at 12 weeks apart. Okay. So your unit measure here is going to be 40 units of, so 40 IUs per ml is or less is considered low risk. Above, to low titer, 40 to 80 is considered moderate titers, and over 80 is considered the high titers. So you may wonder, can I test my antibodies in any platform? Well, the answer is, right, nobody's gonna stop you, right, from doing what you want to do, but only solid phase currently is the accepted method for the criteria. The good news is that there, because of the laboratory technology out there, for example, chemiluminescence and non-solid phase lysis, they are looking at, they are trying to investigate whether other platforms can be the equivalent of solid phase lysis. But for now, to establish your diagnosis, you need to have solid phase ELISA. Okay, and so the ELISA protein, the ELISA you can test, you can test carolipin, beta-2 glycoprotein I, either domain 1 or non-domain 1 subsets. Okay, so again, solid phase ELISA is the only accepted criteria. A risk profile. So what if you have patients, right, that so if you only have lupus anticoagulant testing is positive, and your beta-2s and ACLs are both negative, low risk. And also vice versa. If you only have the antibodies, but if you only have ACL and beta-2 glycoprotein I without the lupus anticoagulant, then you're also low risk. It's when you have lupus anticoagulant positive and one of the antibodies or both, that's considered to be high risk. Okay, so you may have a triple positive patient, which may be positive for lupus anticoagulant, ACL, and the beta-2. So, so note here that the beta-2 glycoprotein I shows strongest correlation with thrombosis, and that lupus anticoagulant assay, lupus anticoagulant correlates better with thrombosis than ACL carolipin antibody by itself alone. Okay, so this is just like a summary, right? From the criteria from 1999, you have the 99, right? And back in 99, they recognized formally ACL, IgM, IgG, 6 weeks. And back then, beta-2 was still being, right, discovered, right, as importance. In 06, they recognized both beta-2 and ACL, IgG or IgM, and they stretched it out to 12 weeks, okay? Because, in 6 weeks, right, you might still be in the acute phase. So basically, but in 2023, you notice that the IgM, I'm not saying it's not important, because if you have IgM only, you may still use that as an entry criteria to keep your patient right on the radar, but that by itself, in the absence of anything else, no longer is enough to make a diagnosis of APS. Okay. Okay, so and again, this is just the criteria and how they validated from the actual document. So next we're going to talk about the lupus anti-clotting. Lupus anti-clotting is going to be in domain number 7 of the 2023 classification. So let's look at before we go there, right? I have to talk about the boring stuff, okay? So PTT, right? So let me teach you a mnemonic, right? How do you memorize this? What is 10 divided by 5? 2. There you go. That's a common pathway. 10 divided by 5 equals 2. Fibrinogen is factor 1, okay? Prothrombin is factor 2. Again, 10 divided by 5 10 divided by 5 equals 2. And then lastly, we have 1. Now, what's easier to memorize, right? All this, or how many of you want to memorize one thing versus 4 things? 1, right? So if you know that factor 7, well, sorry, I lied. Okay. Tissue factor used to be factor 3, okay? But anyways, so if you remember factor 7, right? As the extrinsic pathway, well, everything else, that's interesting. There. So also keep in mind that factor 13 is not measured by the PT or the PDT. Factor 13 is involved in fibrinogen fibrin cross-linking. And that's after the reaction to the PT-PDT. Okay, so how do you run a PT-PDT, right? What is the end goal of the reaction? The end goal is to form a soluble fibrin clot. What you're going to need, right? So those of you who like baking, right, take notes because, right, this is how you're going to cook at home. So you need platelet poor plasma. You need phospholipids. Why do you need phospholipids? Because you want to simulate. The reason why you must add phospholipids is because you want to simulate activated platelets because you're using platelet poor plasma, right? The coagulation does not happen in a vacuum. It happens on the surfaces of activated platelets that has phospholipids. Okay? So depending on your reaction, you can use abdominoplastin, which is the prothrombin time, or you may use like a for APTT, right? You can silicate, C-lide, or kaolin. And that's why you wonder, we never run correlation testing in glass tubes because glass is making silica. We add this, we incubate the reaction at 37 degrees Celsius. We add calcium. Why? Because we brought blue top, right? Blue top uses sodium citrate, which binds to calcium and inhibits clot from forming. So you're actually reclassifying the sample by starting clot. So basically, when you add calcium, the clot begins, and you record the clotting time to when you form a clot. Now, one of note, this is something about lab, right? You can trust the lab because in the laboratory we must never use any reagents that are expired. So you can see correlation in baking, right? You have activator, you have calcium, you have phospholipids. I'm not making this up, okay? Eggs are excellent source of phospholipids. Okay, this is the truth. So on the left here, so one day, right, my wife was making some scones, but then it turned out that the yeast that we had in the fridge was expired. So as a result, the scones never really rose. So okay, they're gonna go to the dogs. Of course, our dogs will eat anything, and they just ate everything in 5 seconds. Anyways, so there you go. So how about the lupus anti-clotting, right? What is the lupus anti-clotting? This is something that's been described since the 1950s and 1970s. The name itself is a misnomer because now, but let me tell you why, right? Lupus this was first discovered in the patients that have lupus, right? SLE. But it was seen actually in a patient that has bleeding. So when they measured, right, the PDT, So we know that the PTT was used for years. It's still used in some places to monitor for heparin. And we know that the PTT gets prolonged, right, when you give patients heparin. So in these patients, the PTT was also prolonged. And you can see that in a patient with lupus, patient bleeding, maybe this is maybe this thing is causing, right, an anticoagulant, right? Now, we know that lupus anticoagulant can most oftentimes will cause thrombosis, but causing bleeding, it can happen too. So I think that it's again, right, and so they're called anticoagulant because unfortunately they interfere with the phospholipid binding process that are clot-based methods, and as a result, you have a pattern of testing that is like the clogging time is prolonged. So like the antibodies, they're also a heterogeneous group of immunoglobulins, right? They're autoantibodies. They're oftentimes they're separate. There's a separate entity from the anticarolapin and beta-2-glycoprotein I antibodies, but they detected functionally by modified clot-based assays based on the PT and PTT. Okay, so in the past they demonstrated reactivity against prothrombin, which is factor 2. Antibodies against, in these patients, they can cause bleeding, right? Negatively charged phospholipids or any phospholipid-bound proteins. Okay. So in the past, right, when you work up a lupus anticoagulant, what happens when you have a prolonged PDT? You perform, right, mixing study. So mixing study is what I consider extension of the PDBT. It's like a screening test. It will tell you that it will tell you the nature of the problem, but it will not tell you the problem itself. Because mixing study outcomes, it can be fat deficiency. You may have an immediate inhibitor, like you see in lupus anticoagulant, classic, right? Or you may see a time-dependent inhibitor, which means when you incubate the sample for 2 hours, right, the sample clock times become normal, and then it becomes prolonged in incubation. So I don't know if this is, but I like to say that when you have a shot of, when you mix a espresso with milk, you get something different, right? Like a latte. But what happens when you get a cream of chicken, right? I mean, this is very salty, right? I mean, opposite alone, right? What happens when you mix a cream of chicken with milk? It still tastes like cream of chicken, right? I mean, I never done before, but I'm just, this stuff is very potent. Okay, it's got spices. So the problems with the PTT screen, right, with the mixing studies is that depending on what reagent you use for the PTT, the PTT may not even be prolonged to begin with. There may be fat deficiencies with the lupus anticoagulant. You may have, now, you talk about short staffing, right? I mean, it require a tech needs to be present for 2 hours to complete the testing, and also 1/3 of your lupus anticoagulants may show some time dependence, just like a factor VIII inhibitor, which you have to exclude, by the way. So the principles of lupus anticoagulant assays. So the lupus anticoagulant assays, right? We know that the lupus anticoagulants interfere with the phospholipids. So that's why in the screening test, right, in any LA screening assay, you want to use a low phospholipids. Okay. Now, like any good screening test, you want it to be able to demonstrate an abnormality. A good confirmatory test is going to tell you, it's going to pinpoint the problem for you. A confirmatory lupus assay is you add a high, overwhelming amount of phospholipids. You neutralize the inhibitor. So again, don't quote me on this. I never done it myself because I'm not the one that's going to do this. But if you buy 160 liters of milk, in theory, right? I mean, I'm not going to do that. If you mix the cream chicken with this, what is this going to taste like? If I tell you it's milk, well, but think about 50 gallons, 160 liters of this thing plus 1 can. You're probably not going to taste the cream chicken, right? If you do 1-to-1, right, it'd be awful. But so, anyways, yeah, so basically you're overwhelming the inhibitor by adding a high concentration of the phospholipids. Now, the results of the lupus assay, it may be reported, and depending on what test you use, right? You may use the percent correction, you may use the test ratio, or the time difference in seconds. So when it comes to testing, according to the latest ISTH guidelines, we do what's called a normalized ratio, because on the left here, right, is a simple calculation for percent correction. How many of you would, if you have a choice, how many of you would calculate you want to do the one on the left, one on the right? I mean, what's easier, right? So why bother doing this? This is not wrong, but isn't this easier? Well, the problem is that, well, my simple explanation is just like you, is it wrong to use the PT to monitor for warfarin? No, right? You can use the PT all you want, but you must know the dermoplastin reagent, right? That the reference PT, and it's just a pain in the butt. So the simple explanation for why do we use normalized ratios in lupus testing is to account for the mean population, right? The same concept as how you use the INR for the P instead of for proton, the same rationale for using the ratios instead of test value in seconds. Now, incorporating, right, mixing studies. This is also important. Why do we perform the mixing study, right? Why do we mix this for 1-to-1 with normal plasma? Well, one, it corrects for factor deficiencies. It decreases potential for false positives, and it also eliminates the need for a conventional mixing study. So you kind of, in a sense, you're doing all this at once, right? You're running the lupus assay, right? But you're also incorporating the mixing step as part of the study. So, so instead of running the patient, right, sample by itself, you would mix the patient, and you would, use a ratio to calculate the actual percent correction in this example. So let's look at the pathways that are tested by the assays. Okay. So there is the DRVET test for the common pathway. PTT pathways, right, are tested by the PTT-LA, SCT, and the KCT. And then for the PT pathway, there's the dilute proton. Now, I'm not going to go over these text to extra ratio, KCT, and dilute PT, because these are very tedious, and they're typically not performed, and also how they apply to the APS criteria had not been yet validated. Okay, so I'm going to go over only DRVT, PTT-LA, and SCT. So DRVT, that stands for dilute Russell Viper venom type. This is from a snake, right? This is derived from the venom of a snake called Dabiola russellii. I guess Russell is the easiest. So this is native to the Indian continent, and it likes to eat rats, reptiles, and scorpions, and whatever. But if you're wondering why snake bites are deadly, it's because the snake venom directly activates factor 10. Factor 10, right, is the start of the common pathway. The coagulation should not happen, right, in vivo without some type of extrinsic or intrinsic activation. So the snake venom can directly activate factor 10 and trigger coagulation to occur. You can draw the body in DIC, you can die from that. Okay, but the good thing about using DRVT is that you can bypass any of the intrinsic and extrinsic factor abnormalities the patient may already have, and you're focusing on only the common pathway. So this is a common pathway factor assay. Okay, and for the phospholipid, it uses dilute riboscephalin or rapid brains. So the lupus algorithm So lupus encapsulation, if it's present, it will interfere with the prodominance complex, which is activated factor 5 and activated factor 10. So DRVUT can be used. So you may use test ratio, which is screen divided by confirm, or you can use what's called a percent correction, which is subtract screen ratio minus confirm ratio divided by screen ratio. When the percent correction is greater than 10%, or when you use the locally established reference cutoff, then your test is positive. Or when the test ratio is greater than 1.20. Okay. So here's an example of a calculation of DRVT. Without explaining further, I just want to say that in our lab, in one of Janet, our lead tech in calculation, she calls this the devil's worksheet because you got so much, right? Test ratio, screen minus confirm, divide by UPP, and this, right? It's just like, so, but anyways, so long story short, right? You use a mixing study and you use screen confirm to calculate a percent correction. And if correction is over 2%, it's positive. Again, this is the devil's worksheet. So how about, okay, let's talk about next the PDT, right? This test, so this is the lupus sensitive PDT with the PDT-LA, and also the test, but there's a test called the Stekel LA that's from a company called Diagnostics Stago. This is a company in France, I believe that they were, I think they were originally in France. But they're across the world. You use a silica-based activator to start the PTT reaction, right? And the phospholipid that's used is also from rabbit race. Now, when you run a screening assay for PTT-LA that is prolonged, then you run a confirm assay. Now to confirm does a couple of things. It essentially repeats the PTT-LA, but with a 1-to-1 mix with normal plasma. And it has the ability to neutralize 1 unit heparin. Tube 2, you add what's called the hexagonal phase phospholipids, basically, right? And excessive amounts of phospholipids that are found in endogenous in cell membranes, right? And you calculate the difference in the time to clot. If tube number 2 clots greater than 8 seconds than tube number 1, that test is positive. If it's less than 8, then that's negative. So PTT-LA and Stekel-LA. Now, silicon clotting time, right? SET is also a PTT-based pathway, but this test is actually designed by a company called it was first released by a coalition company called Instrumentation Laboratory. Now it's part of Warford, right? Nationwide. So it also uses silica, but unlike the PTT-LA, right, Stago, this phospholipid is vegan. So this is vegan. The phospholipid is a synthetic version called, I mean, the brand name is Hemocell, but I don't think anybody else sells this, but it's vegan. Okay, it's vegan. So I don't know, but anyways, so the SET is calculated by a normalized ratio. So you get, again, right, you get a screen time, and then you get what's called mean of this SET screen reference range, right, in seconds. And then you get confirmed, right, and then you confirm. So this ratio, if it's over 1.16 seconds, then the SET test is called positive. Now, okay, well, what's all this, right? How do you explain, right? What is the mean of the reference range versus result of normal plasma? So in a laboratory, how do you calculate a reference range? Like, why is the test high and why is the test come low? A reference range is calculated based on testing of local, right, individual donors here that are otherwise healthy. You get the average, and that average is your mean of the reference range. And then you have two SDs on one side. if so two SDs on one side, if you fall outside the range, say you have an abnormal test, which means that, by the way, every 5% of people randomly, right? We have 100 people on the call today. If I pick out 5 of you, I presume everybody's healthy. 5 of you might have a abnormal value, but that's okay. Now, what is normal pool plasma? Normal pool plasma, this is a reagent that is manufactured by combining, right? So these donors, right, may donate plasma by apheresis, and altogether, everybody's products pulled together from healthy individuals, and basically manufactured into reagents, and you test the clotting times, right, of the plasma by itself. So essentially, the results of MPP, this value may change if you're using that as a bottom number of the ratio. Whereas if you use the mean of the reference ranges, that number is going to be constant. So, so on the right here, I have an example, right? Your mean is going to be the same, but when you test aliquots A, B, and C, they might give you slightly different values, and that may or may not affect the calculations. It should not, right? But okay, so PTT-LA versus SCT, which is better? So it turns out that SCT, because SCT SCT is less sensitive than the PTT-LA. But when you combine SCT with the RVUT, or it's comparable to when you combine PTT-LA with the DRVUT. So the take-home message is that the SCT might be more specific. It may not be as sensitive, but you combine that testing of that with DRVUT, it's going to make it more comprehensive. So let's look at so there's also some updates, right, in the ISTH guidelines of how do you what should you do about screening, confirm, and mixing step. So in 09, right, criteria in the 09 guidelines, you perform a screen. If the screen is prolonged, then you run the 1-to-1 mix, right, ratio. If the 1-to-1 mix is also prolonged, then you run the confirm. Now, what 2020, what they advocate for is when the screen is prolonged, you run the 1-to-1 mix screen and the confirm by itself at the same time. If the confirm is also prolonged, you run the confirm with the 1-to-1 mix. And this step can reduce the number of false positives. Also, what I find interesting is that they actually discourage people from testing if they're on vitamin antagonists or even heparin and DOACs. Whereas prior in 09, they say check the R&R, should be okay. Okay. So, but then criteria that's unchanged is that pathologists should be the ones that are interpreting the test by percent correction or the ratio, and you must use both methods, right, to have a complete workup. If you just test for DRVT and it's negative, you may miss the other one, right, SCT or PTT-LA. Okay. And again, testing must be done at least 12 weeks apart, or approximately 3 months. So this slide shows you that when you incorporate the mixing step, it reduces the number of false positives from 91% positive on the study down to 34%. So that's nearly a 3-fold reduction in the number of false positives that were. I'm sorry. There's a 3-fold reduction in the samples that you call positive. So you can see that a good number of these are probably false positives with a confirmed hold. So it's very important to run the mixing step with the confirmed. So essentially, if your screen ratio is elevated, confirm ratio is also elevated, but your screen confirm ratio is normal, then your lupus assay might be negative, but you have demonstrated a non-phospholipid-dependent inhibitor, such as heparin, right, or DOACs. If your screen ratio with the mix is normal, confirm is normal ratio, you have effective efficacy pattern. only when you have a ratio, screen ratio that's mixed, elevated, right? And then confirmed ratio mixes back to normal. This can elevate the SCS screen confirm ratio, and this will be indicative of a lupus analog. This is important because we want to decrease, right? We want to keep in mind that we want to decrease false positive because we want to reduce overdiagnosis and over treating patients. We know that anticoagulation have risks, right? So if we look at the evolution of the criteria, the criteria from back in '99 spelled out the whole ISTH guidelines word for word. Right, first, right, prolonged screening, then right, non-correction with the mix. Next is correction with the phospholipids, and so okay, also okay, we're gonna just quote the criteria whatever they have, word for word. No 6, and the increased interval to 12 weeks. Now the 2023 criteria, right, is a bit different. If you have any positive lupus assay testing within the last 3 years, even if it's IgM, even if it's oh my bad. If you have any positive right, lupus and endocrinological clot-based assay, my bad, the IgM is different. You may use that as entry criteria. And if you were to test the patient again, and the patient is still positive, well, then guess what? That counts as a persistent positive. 3 years is way longer, right, than at least 12 weeks apart. But it is still at least 12 weeks apart. Okay. So they also recommend that you use a 2-test system. For example, you test both the DRVT and the SCT. And you need to have at least one of them being positive. Now, if they're both positive, then you don't need to, it's not going to count more if they're both positive, but you need at least one test system to be positive. And also what I find interesting here is that they say that if patients are on anticoagulation therapy, biomechanical antagonists, right, heparin, DOACs, test results should be reviewed and confirmed by an individual who has expertise in performing / interpreting the assay. I kind of find I find this a little bit vague, but I think this is talking about pathologists. But hey, I mean, if anybody here want to give it a try, by all means, be my guest. I mean, but because this is an individual who has expertise in performing interpreting the lab assay. So also what I find interesting is that biomechanical antagonists are no longer recommended by the ISTH guidelines, but here, well, what should say, they're discouraged, right? You tell patients they should not be on biomechanical antagonists, but here they say you can interpret with caution. So who's right, who's wrong? I mean, I don't think anybody's wrong here. I think this. So again, everything I just mentioned is under lupus anticoagulant and clot-based assays fall into domain number 7. Okay, so last section is lupus anticoagulant testing. So we have some challenges and anticoagulation challenges, and how do we mitigate, right? Problems that we see with patient anticoagulation. So let's look at the classes of anticoagulation in general. You have your biomechanical antagonists, which is essentially warfarin, and then you have your heparin is oftentimes used inpatient, was unfractionated, but you can also some patients who cannot tolerate this can also be on the low molecular weight heparins. And then you have your direct factor inhibitors or DOACs. Now the O in DOAC stands for oral, right? But your factor inhibitors might be oral or IV. You can have your direct drop-in inhibitors or factor 2A. You may have your direct factor 10A inhibitors. And currently undergoing trials is currently in the works. There's a couple of, I believe they're currently on phase 2 clinical trials. Factor 11 inhibitors and factors of the tissue factor inhibitors too. Okay, so the ultimate question is, can lupus anticoagulant testing be performed despite the patient being on anticoagulation therapy? Well, I think this is a decision that we must consider both what the laboratory implication could mean for the patient. Also, look at how well can the patient tolerate, right, not being on medications. Because DOACs, right, have a much a quicker onset of action. But when you pull the plug, they're also back to their native risk, right, before they're on DOACs. So if you take patients off their anticoagulation for warfarin, right, for a couple of weeks, guess what? You're gonna increase the risk for getting a recurrent, right, thrombosis. And so is that best for the patient? Can it tolerate that, right? But then you also want to know if you have enough entry criteria, but all you have is one prior positive lupus anticoagulation assay. I'll give you one example. Right? Patient comes in, right, to the hospital, right, has had a DVT, right? This is a 40-something-year-old male, right, with no risk factors. Sure, right? I can say, let me draw the first lupus anticoagulant. Let me draw the first anticoagulation, right? And LA testing, right? The Domville testing. Well, you shouldn't do. Let me draw the assays before the patient started heparin. And then this LA test comes back positive for like an SET or DIVT. Patient gets discharged, right? Patient gets discharged on they're first on heparin. They get discharged on a DOAC. So do you want to stop the DOAC, or can we stop the DOAC safely? But we know that if the patient does not have another, but if we know that patient is going to test positive again, then he or she may be classified as APS. But hey, what I do, right? The patient's on DOACs and we're reaching DVT, so do that. So here's a recent article that talk about lupus anticoagulation testing during anticoagulation, including DOACs. And essentially their summary key points is testing for LA is very common, right? And as LA is associated with thrombosis, these patients are already on anticoagulation therapy. But these therapies interfere with the assays, and these may result in false positive, or sometimes, right? Patients, for example, on apixaban might give you false negative, right? And they describe avoidance of testing for the patients on anticoagulants, right? You may switch the patient to a low molecular weight heparin that has less assay interference. You may test the patients at their trough levels, or you may use anticoagulant neutralizers. So this table here, it summarizes that the lupus assays may be affected by the APTT. It's going to affect, right, PTT-based assays, the SET, and the DRVT. It's going to affect everything. But so if you're wondering, should we even run the assay on a sample? Well, guess what? You can use a screening test. You may use a prothrombin time, for example, to see if the PT INR is prolonged, right? Is there any warfarin effect? The prothrombin time is a very sensitive, right? In fact, it's way too sensitive to catch the effect of direct droplet inhibitors and also heparin. And then lastly, the anti-10A assay measures the degree of medications against factor 10, which may include warfarin. I'm sorry, it can include heparin, low molecular weight heparin, and DOACs. So this is more of like I guess I could say you have a net, you catch more fish, but you gotta know what you're working with, right? So warfarin has no direct impact on the factors because it reduces the making of vitamin K dependent factors. It acts by inhibiting vitamin K oxide reductase in the liver. And what you see is a factor deficiency pattern mixing studies. What you'll see, and both the screen and confirmed is going to be prolonged. Now, oftentimes when I see a patient with positive LA, right, the screen can be in the over 100 seconds, right? The confirm might be in the 50 seconds, 50 or 60 seconds, right? So is that a problem when it comes to testing? Well, if you have a patient, I'm actually quoting a colleague of mine here from UCSD. In his lab, if he uses INR of less than 3, you're probably going to be okay, right? You still have to interpret. You still have to interpret the results with caution, but INR 3 in general is not going to affect your because you have the one-to-one mix, right, in the test. So, and if you run it based on PT, you should be careful. So let's look at heparin. Unfreshing the heparin, right? We know that heparin is a common anticoagulant that is used in lines, right? In your indwelling lines catheters. So if you don't flush a line, right? If you don't draw the adequate between 6 times the amount of dead space in the catheter, you might have heparin contamination, and that will lead to issues with the lupus assay. Now, so heparin will see an inhibiting pattern, right, on mixing study. So your screen and confirm again are both going to be prolonged, but they will not correct with one-to-one mix. So the good news is that most of the lupus assays are going to have, they can neutralize heparin up to 1.0 units, which, by the way, is already above therapeutic. The therapeutic range of heparin by the 10A assay is between 0.3 to 0.7. So 1.0 gives you adequate buffer, right, to neutralize this. Also, you can perform a screening of Dobbin time. If this is very prolonged, then so your DRBT assays can neutralize up to 1.0 units. SET used to be 0.4, but I don't think anymore. And then the cycle LA, right, it's going to be like that. So, take home message is that your low molecular heparins have less effect on the lupus assay, but you may still have false positives. Okay, so again, so how about DOACs? DOACs are different because they can cause indirect inhibition of the clotting factors, right? For your heparin and warfarin, but DOACs cause direct inhibition of the factors. Your rivaroxaban, edoxaban, apixaban, or your factor 10A inhibitors, they can cause mostly false positives, but apixaban can be false negatives. And your direct Doppler inhibitor, ticagrelor, also can cause false positives. Okay, so what you can do with the lupus, you may test at the trough levels. You may estimate, you may actually perform a screening at the 10A or a dilute drop-in time. But the problem is that these tests may not always be available. You can also use switch the patients to temporarily switch to low molecular heparin, but then you got to worry about compliance, right? And then lastly, I'll talk about the DOAC neutralizer. So there are 2 out there currently that are commercial, called DOAC filter and DOAC stop. They're essentially charcoal tablets that you put in the sample, and it just absorbs all the sample data. Okay, and so this is an example of DOAC stop that neutralizes the direct drop-in inhibitors. You see before and after, it's a decrease in that. Argatroban is IV and ticagrelor is PO. And here's a DOAC stop that neutralizes the direct 10A inhibitors, so apixaban and rivaroxaban. Again, you see baseline high, right, and it goes down to basically it neutralized in your study. What the problem is the study is that this is something that's only been recent in the last couple of years. So the studies are currently kind of small. So their sample size limited to 100 or less. And in fact, in a couple of case reports, they've actually reported incomplete or partial neutralization, which means, right, it's no good. So, but it just works. You allow the patient can actually keep on taking the DOACs, not having to stop it. And if they don't have any beta-2 glycoprotein or cardiac antibodies, you may actually be able to use that second sample as a diagnosis, okay, to classify as APS. So again, warfarin, 1-to-1 mix, although who's right, who's wrong, we don't know. Heparin maybe oftentimes can be neutralized, right? Low molecular weight can be okay. As long as it's not therapeutic, and DOACs, you may test it. Now, I find this to be challenging, testing a trough, because you tell the patient, right, take your DOAC class at 2 o'clock in the morning and then come here at 9 o'clock in the morning and you get drawn. It can be challenging, right? So I favor a neutralizer, although this is, still a new, something on the block. So the takeaway point is that these strategies are not foolproof. Always interpret the tests with caution, especially when you have results that are borderline positive. Okay, so take-home messages. So the 2023 criteria improves the diagnostic specificity of APS. It does not address everything, but improves by a great amount. IgG antibodies have the strong association with APS. Lupus testing needs to be performed with 2 methods, with screen mix and confirm mix to avoid false positives. And we have mitigations of medication effect should be taken with caution. So having said, last week a week before was actually lab week. I'm not sure if this I'm not sure we have here in South Africa. National Lab Week is basically an excuse for lab to celebrate. I mean, without a lab, right? You only guess. So this is my coac. This is Janet. Julie, our coac crew, laboratory techs. And any questions?
Thank you so much.
Awesome. Pleasure.
Great, Jesse, thank you so much. Please, everyone, add your comments to the chat. I'm very, very happy to see so many laboratory team members here today. I see also colleagues from all the different units in the country. It's fantastic. I'm going to start just with a very practical question from a clinician point of view. So let's say you get a patient with let's take a patient I saw recently. She had a miscarriage a day before 10 weeks. So it's on that edge, first time. Antiphospholipid antibodies were tested and anti-beta-2 glycoprotein IgM positive.
Yeah.
Positive according to the lab values, but the titer or the value was only 16 units per mol. So you haven't reached that threshold of 40 that would make it moderate. So it's an isolated value. There's no history of thrombosis. There's nothing else clinically. So 2 questions. One, my plan was to repeat it in 12 weeks and see if this persists. Patient wants to fall pregnant again. So the question there is, what would you advise? Now that you've got the single positive value, can you advise them to fall pregnant now at any time? Should you wait until the repeat testing has been completed? And then lastly, with all these clinical criteria, nothing obvious, no murmurs, nothing known about kidneys, would you now specifically go and search for all of these in all patients, do heart sonars, etc., to go and see if there are any clinical things present?
Very good questions. I think for number one, right? So we know that lupus anticoagulants, we know that they might be associated sometimes with infection. So I don't know the patient is sick anytime before the past.
So the lupus anticoagulant was negative. It's just the anti-beta-2 IgM was just positive.
Yeah, IgM positive. So, okay. So I guess even so, if you have even when you have one-time pregnancy loss, okay, having pregnancy loss does not predict a second time around. So it's actually so in a sense, there's no contraindications per se to advising a patient not to try again, because, you know, because at this point, right, you know, we don't know yet what the patient's going to be, what the patient, we don't know what the patient's going to be, what she's going to experience the next time around. Also, we don't know what's going to happen. Although I think we may be on something here, but we don't know in 12 weeks, is she now going to have the IgG titer that's going to be forming? Okay, or we test it again, the lupus, or if we test it again, the beta 2 titer might still be low, or it might be negative, or it might rise. So I don't think that I don't think that necessarily having one positive, well, having something that could be positive, because IgM is not, it doesn't even meet the criteria. I don't think that should necessarily change the course of action if she wants to fall pregnant. Because for all you know, you may have pregnancy losses, but it doesn't mean that you're, I guess, having pregnancy losses, it doesn't mean that you're right, barren, I guess not.
Sure.
And second question is what again?
Yes, so at what point would you go and look for clinical features that are not clinically obvious with special investigations?
You know, I think for patients that for patients that are going to be at higher risk, you know, clinically, right? Now, if she had, for example, right, if she had second time around, second miscarriage, then it might be time to have like a closer look to see if there's any, could there be any other manifestations that could affect, that could be a manifestation of APS later on, you know, because when you have the, when you can establish, right, when you can establish a diagnosis of APS with a clinical alone, you don't actually need anything else to further, right? Like it's not going to support you even more, right? To even have more criteria, but it is something to be mindful of, right? If the patient has some documented APS, and you know, but I think that if you test everybody, that's going to be that rather might be low yield, and also if you have a normal heart exam, the chances of finding a heart valve abnormality is slim. So
very, very low.
Yeah.
Right, 100%. There's a question in the chat box by Dr. Gary Lorden. He asks about the duration interval for testing in terms of serology and lupus anticoagulant with the new criteria. Do you use 6 weeks or 12 weeks? And does the duration really matter in someone with overt venous and arterial thrombosis who is critically unwell?
So, okay, so the criteria has not changed since 06, as far as like interval time. It's still going to be 12 weeks.
12 weeks, okay.
So we're still everything is 12 weeks, okay, for all the testing. Now, that's, I guess, if the patient now, if the patient is unwell, I think it depends on what the unwell means, because, and does that mean, and does the patient be unwell, does that mean is the patient developing catastrophic APS?
Yeah, so I see Garrick has corrected me here. He specifically means patients with catastrophic antiphospholipid syndrome. Does the interval matter there, or how would you deal with that?
You know, unfortunately, criteria does not really address catastrophic APS. I wish it did, because we actually had a patient at UCI a few months ago that we were doing plasma exchange on for an autoimmune, right? For like an autoimmune, like a rheumatologist, right? Called it like Raynaud's, right? But there's no biopsy. But when I saw the patient that got consent, right? It looked, I'm like, this is catastrophic APS in the back of my mind. But the problem is that she had not had any prior lupus testing before. Now she has a one-time positive, Okay, and now she also was rapidly going downhill, deteriorating very quickly. We were already doing plastic exchange for a suspected necrotizing myositis until, unfortunately, the day before she died, right? I discussed with clinical teams, hey, if this is catastrophic APS, we need to add heparin to this. So, but then the problem part, and I think Dr. Loden has a good point. The rheumatologist said this is not APS because she didn't meet criteria. She only had one positive DRVUT, so this is not APS. So so it's like, what do you do when the rheumatologist says it's APS, but then she's going downhill rapidly? I mean, I think that the issue of catastrophic APS should be investigated further with more research. Catastrophic APS affects like 1 in a few million, so unfortunately it's not easy to come by. But it is a problem. But I would say if you're suspecting catastrophic APS, act on it.
Great, thank you for that. Dr. Evan Bowen asks, thank you for an excellent talk. Is there a scenario where there may be a strong lupus anticoagulant which may overwhelm the excess phospholipid in the confirmed test and may lead you to incorrectly diagnose an other inhibitor?
That's a good question. So the answer is, first part of the question is, yes, you may have a very strong lupus anticoagulant that does not even neutralize the confirmed in the normal ranges. In fact, one of our positive controls, I think our current lot of positive control samples has so much in there that it just the confirmed is slightly above the range. But this is the reason why we don't just look at the screen and confirm in seconds. This is the reason why it requires interpretation by a laboratory individual pathologist, and we use the ratios because let's think about it, right? If your reference range, right, for the screen and confirm is 45 seconds, your screen is 150 seconds, right? Way overboard. Your confirm goes down to 48. Oh, well, isn't my confirm also belong to? Well, you look at the ratio, right? Let's look at the ratios. I guarantee you a screen time of 120, confirm time of 48. That will give you a ratio in the high twos. Yeah.
Great. I see there's another question from Dr. Erika Marinell. Thank you so much for the talk regarding the order of lupus anticoagulant LAC testing. We used to perform screen followed by mix followed by confirm. And then there was new data to suggest that mixing would dilute out a weak lupus anticoagulant, thus increasing false negatives. And thus the order of testing was changed to screen, confirm, mix. We currently only perform a mix if the confirm does not correct the prolonged clotting time. Is the newest data saying that this testing strategy is increasing false positives unacceptably? Should we go back to screen, mix, confirm? I assume when you say perform, mix, and confirm at the same time, that if the result corrects with mix, that it doesn't matter whether the confirm corrects or not. Now that is a mouthful. Did you get all that?
I think so. Yeah. Okay, that's a very good question.
Right.
So I think the latest guidelines. In fact, let me go back to one slide here. So there's a good paper here. So this one right here. So what she mentioned earlier, right? The screen, mix screen and confirm. This is the 2-step process. Now we have the 3-step process. So this step actually when you do a mix with the confirm, with a 3rd step, you're actually decreasing the amount of decreasing the amount of samples that are positive. So in turn, you're reducing the amount of false reducing the amount of false positives. So, so when you're okay, so the when you're mixing, right, you're always going to be at risk for missing out a weak lupus inhibitor. That's always going to be a risk with any one-to-one mix. And that's the reason, like, in our lab, when we in our lab, we're actually in the process of upgrading our instrumentation from the stock of ACL tops, but I want to see all the data. And also, okay, if you have a patient, right? So if you have a patient that has a weak lupus inhibitor, what does that mean for the patient clinically? I guess from a laboratory point of view, we might be afraid, right, that we might miss, right, this, and that we might miss, right, what if we miss this, right? But yet always have to correlate with the patient clinic. So it's like, okay, even if I miss this one, if there's high suspicion, right, you get more to test again, and the next time it might be strong enough. Okay, so some places use what's called, some places used to do 4-to-1 mix, like we mix one part. Wait, yeah, this is like my twist. You mixing 4 aliquots of patient and 1 aliquot of MPP, but those are not. I don't think those are done as commonly much anymore. Okay, so.
I'm going to take one last question from Dr. Yaglan Naidu, who's also a hematologist out in KwaZulu-Natal. And he says, thank you for your talk. I have a prima gravida at 27 weeks who presents with thrombocytopenia, platelet count of 118, an anticardiolipin antibody with an IgM of 32. She was found to have EBV IgM positive awaiting viral load. The APS-LA will need to be repeated in 12 weeks. Can this be a false positive due to EBV? And I want to add to the question, if I may. At the same time, we've seen with syphilis, for instance, that it can often interfere with some of these assays. Are there other infections that can actually cause false positives that we should consider? We're thinking of South Africa with a high HIV seroprevalence prevalence of HIV that's often associated with antiphospholipid antibodies as well. How should we think about that?
Absolutely. So, number one, number one, right? When you say a patient, right, at 27 weeks or whatever, and has low platelets, thrombocytopenia, in pregnancy, right? So in pregnancy, the difference that diagnosis of APS can also be HELP syndrome, or right, HELP syndrome, right, which is preeclampsia plus hemolysis, low platelets, right, and elevated liver enzymes. HELP. So the manifestations. So yeah, I mean, what you're seeing here might be the start of some type of, if it's APS, right? It could be the start of that, but the IgM titer with the IgG is, it's something to think about, and I would definitely say, I would repeat the antibody titers again, probably after pregnancy, right? Because how many weeks has it been? Well, you could, yeah. I mean, you could probably wait until after she gives birth, right? A month or two, and see if it's still there. And that is, and this is the reason why we had to wait at least 12 weeks, because I don't know if this IgM positive is due to the right, positive EBV, anything, right? Any it's been known. So HIV, right? Viral infections, right? These things, RPRs, right? Serologists, syphilis, these essentially, any infections can trigger an antibody that looks like an anticardiac antibody, which then can be detected. Okay, so and hence the importance of retesting the patient if there's any IgG, right? That's more concerning. But if this is purely due to infections, you know, you may only see IgM again, and maybe the titers are going to go down.
I think the question that will come to us as clinical hematologists in this situation, of course, is should we now put the patient on prophylactic subcutaneous heparin for the rest of the pregnancy? Oh, there we go. Jaglan has just asked the question. Should I treat the patient?
Well,
Prophylactically, because of the very high risk of thrombosis and or pregnancy loss,
so
especially thrombosis.
So, I think a decision to put the patient on prophylactic heparin or whatever. Well, only a question. Only no molecular, right? No DOAC. So only so.
Yes.
I think that should be made clinical grounds and not on this isolated IgM alone. Because you talk about other causes, right? Let me show you the slides that I have. Slides that I have axed out. For fun, right? There are a list of inherited and acquired factors, right? There's a list of inherited and acquired causes of thrombophilia. So if the patient might be high risk, right, for other factors, then you would treat the patient prophylactically for anticoagulation, based on clinical grounds. But as far as this patient is concerned, we don't have enough evidence to classify as APS. In fact, we're not even close. But does that answer the question?
Well, I think somebody would say, well, if you look at contraceptives, the pregnancy might give you a similar risk. Now we've also got the platelets that have dropped a little bit, and we've got the IgM. We're very worried now.
Yeah, well,
weighing up risks now for prophylactic, maybe anti-factor 10A guided, like saying should we do it, should we not? I know it's a gray area, and I think that's where this discussion comes from.
Exactly. I mean, I think it'll come down to like patient risk, like risk benefits, because if you put the patient right on heparin, right? If you're on low molecular weight heparin injections, right? Am I going to cause bleeding? Am I going to have this? How much can I tolerate? And I think that's one of the important updates in this new criteria is that IgM is less to be worried about. It does not mean don't worry, but it means you can probably worry less about that. Okay. So especially when you have documented infection, EBV, whereas if anyone can qualify, then should I be concerned? But now IgM is on a lower scale.
Right. So it sounds to me like unless you have something else, then one would rather watch and take a watchful waiting approach. Jason, has been very, very, very useful. Thank you. And there's so many comments from people saying, great talk, fantastic talk. Thank you, thank you, thank you. Excellent overview. You can watch the videos, read the comments afterwards. But I think my own knowledge has gone up more than I expected it would. You think you know something, and then you listen to a talk like this, and you learn so much. So thank you very much. Appreciate it. Thank you for coming all the way.
Thank you very much.
And we wish you a wonderful time in South Africa. Hope you enjoy it.
We will. We will.
Just want to say a big thank you to everyone who stayed on. I know we went a little bit over time, but thank you for staying on. The discussion was really worth it, and I appreciate you coming. So don't forget, next week, same time, same places, wherever you are. We'll talk about joint issues in hemophilia A. Have a lovely evening and afternoon, everybody. Bye-bye.